Surgery, Bloomfield Hills, Michigan. So this is a very nice, interesting case. This is a nice patient who has had 2 sets of implants. The second one was placed 525 cc's below the muscle, relatively very large implant in 2017. And per op note, the surgeon, because of the way her chest size is, he could not go medially towards the midline in order to put the large implant, not superiorly above or laterally, but inferiorly. And so what was done was, as described in the op note, if you have someone, let's say 20-year-old, you have the breast tissue. This is the patient at age 20. When the same patient is 80, for example, you will see that the nipple is going to point towards the ground, but this is where you have the same inframammary crease ligament. Inframammary crease ligament that's going to still be holding this in place. So the surgeon cut this in her in order to accommodate what is a relatively very large implant. So that cut indentation was here, and the patient ended up getting a very large implant at the bottom. Now, I cut out this extra skin right here, which is part of that pseudo lift, such that all of this tissue skin is removed, and now I'm able to literally cinch this in such that she's going to have this recreated back to where she was, so that she would have this inframammary crease ligament recreated. She had what was a double bubble deformity. And so what happens in the double bubble deformity, if I may, you have the implant sitting here, and then you have this outpouching that occurs. Obviously, it's a little bit exaggerated because it's going through, and so you have this indentation. So this area was removed, and this is why you see this excess skin over here on the right and also on the left. So I measured the distance from the nipple all the way down to the crease. It's the same on both. And you can see I cut out the scar, and indeed the implant was working as a tissue expander. You'll see some areas relatively thin, some areas relatively thick, some areas calcified right here, as I'm assuming. Remember, she had a capsular contracture. So I'm going to go in, 100% total capsulectomy performed, 0% of the capsule remaining behind, consistent with what is that 100-100-0 rule. And as I go in, you will see relatively reasonable size, thick. You can actually hear it being cut. Thick capsule. If I take this ruler and I put her here, you will see the thinness of this capsule. No matter how thin it is, it has to be completely removed from the front, from the back, especially when on top of the ribs, because that's the hardest part of the whole case. Intact implant, what I would say in brand new condition, and then you will see on the back some fluid, and you will see this leaching of the silicone from the intact Allergan 525 implant. And as you will see, the entirety of that capsule implant inflamed tissue has been removed, and you can see my green glove underneath, and I'm very happy how the whole dissection has gone. So a big part of the operation obviously is the implant removal capsule on top of the rib, but contouring, that certainly adds another dimension to the surgery, and aesthetically she's going to be very sound, minus any unnecessary cut around the nipple areola up and down. So as you can see, the width of this is much more than right here, because I had to balance the two out. And she had what was that double bubble deformity. You can actually Google it, double bubble deformity. Some areas so thin, some areas thick. The muscle was just covering the top 1/3 of the implant, and as soon as I go in, you'll see again the very thin capsular tissue. All of the capsule has been removed. And the only and the ultimate way to tell if the whole capsule was removed or not is if you see the chest wall pictures and videos. Not over here. And this is where, as you can see, very thin capsule, some fluid on the back. And you can see that stickiness that's present on the middle finger and index. This is your 525 style 8RX with the lot number printed, Allergan implant, 525 cc's. What I would say in brand new condition. So thin, ultra thin capsule. See, this fatty tissue behind has been removed. It's part of the culprit, if you ask me. So in my practice, if it palpates abnormal, feels abnormal, you can see this part of the remnants of that capsular contracture she had. And overall, I'm very happy and content with how the whole dissection has gone. So the implants will be returned to the patient, capsules to be sent to pathology, rule out that rare BILCL CD30 analysis. The double bubble deformity has been addressed on the right and left by removing that excess skin, where the implant was working as the tissue expander and recreation of the inframammary fold that was compromised by the previous surgeon in 17. So she had roughly half the size of the implants when she first got them, her first original set below the muscle as well. Cultures done for aerobic, anaerobic, and fungal. No need for that lift, as she is recoiled relatively very reasonably well. No need for drains, minimal blood loss, twilight deep sedation, and she has the high definition pictures, videos of the chest wall showing complete removal along with this cutting open, and we will see how she does post-op minus her many symptoms of what is clearly suggestive of what is breast implant illness. This is Dr. Khan, Executive Plastic Surgery.